And what we found was it didn't matter whether your gradient was high or low to impact mortality after TAVR or after SAVR, but what mattered was your flow state.
Hello, everybody. Andrei Popp here again. We are honored today to have Amr Abbas join us. Amr is not only a friend, but he was one of my mentors when I was at Beaumont. He is that rare interventional cardiologist who, besides reading echoes, is actually, if I'm not mistaken, board certified in echo, and even more unusually, he has actually done an echo fellowship. Amr, we're absolutely delighted to have you.
Thank you, Andrei. I appreciate that. I do want to make a correction. I didn't quite do a full year of echo fellowship, but I did train at the Mayo, and doing as many echo months as you can was a prerequisite to graduate from there. So.
Well, you taught me a lot about not only cath lab, but echo. And obviously, as everybody should know by now, you have basically written the chapter, not a textbook, on gradients after biological heart valves. And again, you're bringing a very unique perspective to this because you look at the echo, you measure the gradients in the cath lab. And we've talked about this in the past, and I've seen your lectures many, many times. And what kind of prompted this call to you? I saw your recent paper published in JACC Asia about looking at gradients after TAVR. And just to refresh my memory here, the paper is titled Invasive versus Echocardiographic Aortic Valve Gradients Pre- and Post-Balloon Expandable TAVR-in-TAVR in Failed TAVR Prosthesis. And, talking to people in the field, I know this is a great source of, let's say, anxiety with people. If we're putting a valve inside another valve, are we going to get into the Russian doll phenomenon? So tell me what your thoughts are.
Well, first of all, again, thanks, Andrei. It's really a pleasure to always see you and collaborate with you. Murmur MD has really become one of my favorite go-to when I want an update or a quick review of a topic. One of the things that I really want to kind of talk about in lieu of this paper is really just understand this phenomena of discordance that we have kind of described over the last few years, which is really identifying a discrepancy between invasive gradients as well as echo-derived gradients, and trying to figure out what clinical scenario this occurs in and where it becomes clinically significant, meaning there is such a huge discrepancy. I do have a slide. Is it possible for me to share that? Yeah. Basically, what we found is that discordance happens in almost every clinical scenario, whether it's in native aortic stenosis, whether it's in degenerated surgical valves, whether it's in degenerated TAVR valves, whether it's in valve-in-valve, whether it's in TAV-in-TAV. Our last paper demonstrated that this phenomena in TAV-in-TAV still occurs, and there was a significant difference between the echocardiographic gradient immediately post TAV-in-TAV compared to the invasive gradient obtained at the same time under similar hemodynamic conditions, meaning this wasn't an echo done the next day, it wasn't an echo done towards the end of the day, an hour later. And what we found is that with an average invasive gradient of about 1.2 plus or minus 2.3, the echo gradient was about 8.1 millimeters, or roughly, if you think about it, if the invasive gradient is 1, the echo gradient is 8. What was really startling is the next day, or the pre-discharge echo. Now the gradients on echo even increase furthermore, up to 11 millimeters on average. And so what we're seeing here is a change and a difference between invasive and echo gradients demonstrated in TAV-in-TAV, But also in the pre-discharge echo, this echo gradient even increases more. And that is usually the gradient that we use to compare to the 30-day and the 1-year gradient measurements. And so knowing that there's a discrepancy up front helps us calibrate the differences and the true hemodynamic characteristics of the valve.
Yeah, that's very interesting, and I think you know I think we've all seen this. Those of us who check gradients on the table, we generally find that the echo gradients are dramatically higher, and they certainly, as you said, tend to get even higher afterwards. And even in cases where the gradients go up later, in the vast majority of cases where we actually go back and check, let's say, a CTA looking for halt, we don't seem to find it. So I generally tell my people that gradients in the vast majority of cases are a nuisance. They slow you down in clinic because you want to look at the images yourself. But it is pretty unusual for us to have to do something about gradients. Now, you've also published extensively on patient-prosthesis mismatch, and I have my peripheral brain is my phone, and I have a bunch of different apps on my phone, including the TAVR-in-TAVR app, the valve-in-valve app, and the PPM app. And the patient-prosthesis mismatch app is the one that I probably use the least. But I know a lot of people are very worried about patient's prosthesis mismatch, even with TAVR valves. And after talking with you extensively about this, I am not that worried. So tell me how you think about PPM with TAVR valves.
So that's a great question, Andrei. And let me just go a few steps back and explain just something about echo. Echo doesn't really measure a gradient. Echo measures a velocity. And invasive catheter measures a pressure gradient. The velocities only reflect true pressure gradients when there is a stenosis. That stenosis is a restrictive nozzle where the assumptions in the simplified Bernoulli equation work. When you think about valve area from which we derive patient-prosthesis mismatch, a valve area that we calculate is, as you know, something called an effective orifice area, meaning that's not really the area or the anatomical or geometrical area of the valve. That is a flow-derived area which occurs from flow calculations. And when PPM was first described, everybody initially thought that PPM was related to a diminished or an elevated gradient. And then we understood the concept of low flow, low gradient. And so we understood that PPM is now the presence of a low indexed valve area. Now, in the surgical literature that we have suggests that PPM can impact LV mass regression and can impact outcomes. When we started looking at PPM following TAVR, there was clearly some data to suggest that PPM is less common after TAVR. But when you look at how the valve area is calculated, whether invasively or with echocardiogram, it is nothing but a ratio between the flow or the cardiac output invasively or the stroke volume non-invasively divided by a square root or a correlate of the pressure gradient, meaning in its simplified form, the area is nothing but a ratio of flow versus gradient. And so what that automatically tells you is that you can have a low valve area either from a high gradient or from a low flow state. So if you have a low flow state, you can have an echo-derived area that is low, not because the gradient is high, not because there is indeed a restriction of the valve orifice area, but rather a reflection of the low flow. And so what we did in the PARTNER trial is we actually looked at patients following the surgical arm in the PARTNER data, as well as the TAVR arm in the S3 registry as well as in the PARTNER 2. And what we found was the patients were divided into low flow state versus normal flow state. And then those states were then divided according to whether their gradient was high or low. And what we found was it didn't matter whether your gradient was high or low to impact mortality after TAVR or after SAVR, but what mattered was your flow state, meaning the patients who had low flow, low gradient, severe PPM, did worse after TAVR or SAVR than those normal flow patients with high gradient. And so the way that I look at PPM is I try to ask myself, is PPM related to a low flow state or is it related to a gradient state? Another important paper was published by Becky Hahn's group, where they showed that even in patients who had low flow and normal flow, now these are patients that don't have PPM, this was all comers out of the PARTNER data, they found that for a low flow state, the predicted PPM measurement was indeed lower for low flow state versus normal flow state. Meaning if you put in a 29 S3 valve and the patient has a low flow state, the expected valve area is going to be lower than the expected valve area in a 29 with a normal valve state, which again confirms the data that we published from the PARTNER data, suggesting that PPM has to be looked at in the context of flow and not just merely as an area or a gradient. And so I'm less concerned about PPM in patients who have normal flow state, less concerned about PPM with valve-in-valve, and we have data from the TVT registry showing that severe PPM does not impact clinical outcomes up to 3 to 5 years after valve-in-valve TAVR.
This is very, very good information and very important information, I think. And you introduced the concept of predicted PPM, and that is something that the surgical valves have traditionally been using, as opposed to the TAVR valves that have been using the measured PPM. Is that a direction that we will be going in the future, you think, or where do we go with that?
That's a great question, and predicted PPM has been suggested as a method to adjudicate the PPM that is related to the individual patient measurement versus the PPM that is related to the valve. And so in the surgical literature, it's used very extensively in all maneuvers of annular enlargement. Choosing bigger valves are meant to avoid this PPM through the calculation. But I think one of the important things we have to really ask ourselves is, what are we trying to determine? We are trying to determine clinical correlates, or let me rephrase that, echocardiographic correlates of clinical outcome. So for you, is it more important to know that this parameter correlates with a worse clinical outcome? Or is it more important for you to identify this echocardiographic parameter? Meaning, if I use a measured effective orifice area that shows severe PPM in somebody with low flow, we know that that patient is not going to do well. It's not because necessarily they have a low indexed effective orifice area through the measured technique, but rather it shows that the patient will have a poor outcome because of their low flow state. If you take predicted PPM, we found again from the analysis of the TVT registry in the valve-in-valve population that there was some discrepancy between the clinical outcomes based on measured versus predicted PPM. And it all boiled down to what the patient's ejection fraction was. That was the primary determinant of clinical outcomes. And it's previously been reported that severe PPM has worse outcomes in patients with low ejection fraction, because patients with lower ejection fraction usually have lower stroke volume index on echocardiography than patients who have normal ejection fraction. And so when we even looked into this paper on the PARTNER trial to divide the patients with severe PPM into low flow and normal flow and looking at their gradient, there was a subcategory where patients who had low ejection fraction with low flow even did worse than those who had normal flow, a normal ejection fraction with low flow. So I think both modalities, as far as it relates to TAVR, are useful to give you an idea about the individual person themselves, about their clinical outcomes, and the predicted ppm, I think, helps clarify for certain valve types what that valve type is. The question that always comes up, do we need a different indexed effective orifice area for each valve type? Because does every valve type have a different flow pattern and thus have a different expected area and gradient?
And do you think that's related to position versus the annulus, whether they're supraannular or intraannular? Is that where the flow patterns are different, or is it purely the geometry of the valve?
So that's a another very good question, Andrei. And we've got some studies that have looked at flow patterns after TAVR valve implantation. And it seems that there are some models, and this has been known also from the surgical literature, that have different types of flow regardless of their annular location, meaning some valves can have laminar flow, can have turbulent flow, can have mixed flow. And the difference is that laminar flow generates higher measured velocities because laminar flow looks like a bullet. And so the peak velocity is higher. When you have turbulent flow, you lose that apex of the flow pattern, and that causes to have a lower measured velocity. Now remember, echo measures velocity, and then you derive a gradient. So if you measure a lower velocity, you have a lower pressure gradient estimate. If you have turbulent flow, if you have a laminar flow, you have a higher peak velocity, you'll have a higher peak gradient, you'll have a higher estimated mean gradient, which will impact your measurements. So is it related to the annular location of the valve? I believe it's related more to the flow pattern that the valves lend themselves to. Is it laminar? Is it turbulent? Is it a mixed pattern? How much laminar is it? And so forth.
Yeah, and I think that this is obviously a very complex question because you can, especially when you're doing TAV-in-TAV, you could put a sapien inside a sapien and put it at the same level, or you could put it a little bit higher. On the other hand, you could if you put a sapien inside the evolute, that sapien by definition, if you put it at the waist, is going to be supraannular. So I do think with the rate at which we're seeing redo TAV in the US right now, I think we're going to have answers to all these questions a lot more in a few years than we have currently.
Agreed.
So the other interesting paper I saw, and I quote a lot in my talks and when I talk to people, is there was a paper from Gilbert Tang's group where they looked at what they termed extreme annular undersizing of sapiens, where they basically took smaller sapiens, let's say a 23, and they added some volume versus a 26 in a borderline annulus, or a 26 plus volume versus a 29 in a borderline annulus again. And they basically showed that there was no difference in gradient or severe ppm, but there was a minor statistically significant difference in aortic valve area. And that, to me, suggests that the strategy of having better expanded valves rather than larger underexpanded valves may be a winning strategy. Do you have any thoughts on that?
I personally agree with that statement. That's what we've done. We've moved away from putting underexpanded. I shouldn't say underexpanded, but larger valves, but with lesser volume, to smaller valves with larger volume. My personal thoughts on that is that I look at this as a stent. You never want an underexpanded stent, okay? And when you have an underexpanded stent, you can't say that you can do FFR or an IVUS and then expect a normal hemodynamic, result. And so the idea is that you need to optimize that valve and you need to make sure it's expanded. So if you put a valve that is not adequately expanded, first of all, you're going to have leaflet overlap. You're going to have anatomical abnormality. You might have aortic regurgitation. You might have shear forces on the valve. So that's yet to be determined, and I don't want to postulate what that might lead to. But having a valve that is appropriately expanded, I believe, is the ultimate goal. And so if you have a valve that's too big, that's underexpanded, again, this is just my thoughts, I think this would lend itself to some shear forces and overlap and coaptation problems that would lead to problems with the valve in the future.
Yeah, and I think that, that the place where really this comes to bite us is, as everybody knows, these valves are not sized according to what truly the size of the valve is. Neither surgical valves are sized that way, nor TAVR valves are sized that way. They're sized based on the annulus at some level, but in surgical valves, this is very clear. You can have a 23 surgical valve can have a true inner diameter of 21, or can have a true inner diameter of 19 or even 17. Right. Whereas a TAVR valve of, a 29 evolute hosts a 23 waist, and a 29 sapien hosts essentially a 29 waist. But I think people get into this problem when they're looking at a valve that has failed, and they say, well, I don't want to go with a smaller valve. I want to put the same size valve or even a bigger valve. But in the end, the same size valve or the bigger valve will be dramatically underexpanded unless the anatomy permits you to expand the index valve, which is, in my experience, is extremely rare.
Agreed.
And I think that that's the big question, because we have data from David Mayer from the Vancouver group showing that if you put a sapien in a sapien and you're trying to put the same size in, the only way to get it fully expanded is by pre-dilating with a same size balloon, putting the valve in, and post-dilating, which frankly 95% of anatomies do not allow for. And so in many cases, you end up putting a smaller valve that may end up being better expanded and will probably be safer for the patient. And I'm not sure whether it makes a big difference in terms of gradients, but that's really where I get worried, because people look at the label and they say, I'll put a 23 in, and then the 23 comes under expanded, and maybe a 20 would have been better.
And, just on that note, we published an analysis of the TVT registry. Marvin Ng was the first author, and we looked at the clinical outcomes of 20 millimeter balloon expandable valve versus larger valves, and we didn't really see a difference in clinical outcomes up to 3 years. So I think the bottom line is you put the valve which you feel is going to be expanded appropriately, and I think that is key. And I think the paper by Gilbert, I think, points to that. There's not really a big change in hemodynamics, at least by echo, and I can guarantee you there's really no change. There would be no change in the invasive gradient. We, as you know, looked at balloon versus self-expanding valves across all sizes, and we found that the invasive gradients are all the same. What differs is the echocardiographic gradient between the valve types.
Yeah, and I think it's interesting when I started doing TAVRs, and it's crazy to think that it's been more than 10 years. I know it's you were there at the Index TAVR in the US with Bill O'Neill back in the old days at Beaumont. So you've been arguably in the TAVR business longer than anybody else in the US. The teaching that we were getting from our or recommendation that we're getting from our vendors was always put the biggest valve in possible, and there wasn't much thinking about underexpansion and early failure and all that kind of stuff. Now what I hear from my Edwards rep is put a smaller valve and make sure that it's well expanded rather than putting a bigger valve and, as you said, subtracting volume. I really can't think of the last time when I put a valve and I took any volume out, and pretty much every TAVR day we add volume to valves.
Yeah, and I think that's true also. That kind of mental concern about putting a larger valve or a bigger valve has, I think, if you look at the SMART trial, a very large percentage of the patients received in the small annulus a 29 millimeter valve. And so that certainly points that the operators were attempting to put larger, valve sizes if obviously it was safe and permitted. The other thing is to take back a historical point, in the early TAVR days in 2005, when I was a fellow with Bill and George Hansel and Ted Schreiber, when we were doing the first case, there was only two valve sizes at that time, a 23 and a 26, and there was no CT and there was no sizing, and it was a guessing game who got, a 26 valve and got a 23, but there was no skirts around the valves. And so the idea was, when we started noticing this PVL phenomena, we first sent it as an abstract to the ACC in 2006 from the collective TAVR experiences in the world with Alain Crebier at that time was 50 patients. And it seemed that the patients who got the smaller valve size had more PVL. I mean, that was a lot of thought then, was it to put a larger valve size to prevent the PVL. Now, with the skirts and with the change of the technology, I think the movement has changed, but I certainly think a well-expanded valve, the newer generation valves, is the ultimate goal, whether it's the self-expanding or the balloon-expanding platform.
And I think, in TAV-in-TAV, that generally, I mean, even if you put a larger valve in, you're probably not going to harm the patient immediately. We have pretty good data in my mind that, again, if you want to get a fully expanded valve, you really have to pre-dilate at high pressure, post-dilate at high pressure, that kind of stuff. And most people who put the larger valve in probably don't do that, so the patient doesn't get harmed initially. But I am very much concerned that it could lead to early failure, which we don't yet have good data for, but it's certainly a concern in the back of my mind. But I do think that in native annuli, especially if you have a lot of calcium, you get a lot more safety from going small and adding volume than going big and subtracting volume. And I think it's reflective of the fact that we're practicing that a lot more, that the rates of annular ruptures, the rates of annular rupture is extremely low these days. I think it's something like 1 in 600 cases that based on literature review I did recently. So I think that strategy helps you in more ways than one.
I think you're absolutely right. I mean, I think some of that too is, before in the original balloon expandable valve technologies, because of the absence of the skirt, the classic teaching was you can accept a -5 to a 20% oversize. And then one of the studies that, I think made me look at it differently was a study that came out of Japan that looked at, in the newer generations with the skirt technology, allowed you to not have to expand that much, right? I mean, you probably need about an 8% expansion, which is the sweet spot between preventing PVL and at the same time, not increasing the risk of AV node impingement and pacemaker. And so I think in that technology, the question is always, how much extra is enough? And I think everything is a yin and yang, right? I mean, you want to know how much you've expanded to prevent PVL, but you don't want to overexpand to impinge on the AV node, or do you implant the self-expanding valve higher to avoid permanent pacemaker? But then what does that do to the future TAV-in-TAV planning that you have? So everything always has a pro and a con, and there's a balance. And I believe at some point there's a sweet spot for all of us.
Yeah, and I think, how passionate I am about lifetime management, but what I tell people is, there's a lot of times I see somebody who comes around and says, well, this patient's, annulus is, let's say, 340, and I'm going to put a 23 valve because that gives me the option to put a 20 in the future once this fails. And my problem with that is that 23 will end up underexpanded, taller than a 20, and certainly taller than a overexpanded 20. And if you put a 20 and you get it well expanded and then it fails, you probably will be able to put another 20 in. But if you put a 23 and it fails and it's grossly underexpanded, you will probably still put a 20. So
Mhm.
I I try to think of all those aspects, and I think what I heard from you today and what I've seen in the literature is that it's probably more important to have good expansion, and that I'm probably correct in not using my ppm calculator very much, especially when it comes to TAVR valves, and especially with TAV-in-TAV, there's such little data to show harm, if any. I don't know that there's any. Um, and I think as you said, we look at the totality of the patient's experience, their anatomy, and we worry a little bit less about ppm with TAV-in-TAV and more to getting the best expanded valve we can.
I think you're absolutely right. I think we now understand that it's not a matter of area and gradient. I think it's really important for us to understand the flow state, the ejection fraction, and the invasive gradients. I can see that flow chart in the future gives us a better understanding about the prognosis of the patients, how they feel. And at the end of the day, we're here not to fix numbers. We are here to heal patients. And we certainly have to move from that mindset of focusing on numbers and digits and comparing that to really understanding what really is the clinical impact at the end of the day for our patients and their lifetime management.
No, I think that's a great thought to end this on. So, Amr, as always, thank you so much. I learned a lot today, and I hope to do this again in the future.
Thank you so much. Thank you, Andrei. Appreciate you having me.
Thank you.